warm welcome to all of you for joining me for another session in surgery for undergraduates. Today's topic is on chronic pancreatitis, which is a dreadful disease which is chronic and debilitating to the patient. First, the introduction. What is chronic pancreatitis? Chronic pancreatitis is a chronic, as the name suggests, is a chronic inflammatory disease of the pancreas, resulting in a progressive and irreversible damage to the pancreatic parenchyma, leading to a loss of exocrine as well as endocrine functions. The incidence of chronic pancreatitis is quoted as between 2 to 10 new cases per 100,000 people in Western countries. It has a male to female ratio of 4:1 and an average age of onset of 40 years. Okay, to understand, before we proceed with the further details of acute pancreatitis, this is to refresh our minds on the anatomy of the pancreas. Okay, this is the pancreas situated in the C-shaped segment of the second and third part of the duodenum. Okay, it consists of exocrine and endocrine tissues and is drained by the main pancreatic duct, okay, which joins the common bile duct and forms the ampulla, and this will then open into the major papilla, which is guarded by the sphincter of OD. Okay. Okay, this is the pathology of chronic pancreatitis. Okay, there's chronic fibrosis, inflammation, chronic inflammation with fibrosis, dilated pancreatic ducts, fibrosis causing strictures. Okay, you have got stones in the pancreatic duct. There are segments of dilatation and segments of strictures, and the whole pancreas finally becomes atrophic. Initially, it is bulky and swollen, and later, with recurrent attacks of inflammation, becomes fibrous and shrunken, similar to cirrhosis of the liver. So, finally, the pathology of the chronic pancreatitis leads to duct occlusion, inflammatory cysts, stricture and dilated ducts with calcified stones, and an enlarged, hard and fibrotic pancreas, leading to a loss of exocrine and endocrine function of the pancreas. The etiology of chronic pancreatitis. There are two main causes of chronic pancreatitis. It's either chronic alcohol abuse, which accounts for about 60% of the patients, and the second large group is the cause is unknown, idiopathic, it's about 30%. The remaining 10% comes from these conditions: metabolic causes like hyperlipidemia, hypercalcemia, infections such as viral, HIV, mumps, Coxsackie, and bacterial such as Echinococcus, can be hereditary or familial, example in cystic fibrosis, can be autoimmune induced, such as autoimmune pancreatitis, or accompanying cases like in SLE, anatomical malignancy or stricture formation, congenital anomalies, pancreas divisum, annular pancreas. So these are all the less common causes of chronic pancreatitis. The clinical presentation of chronic pancreatitis, recurrent. The main feature of chronic pancreatitis is recurrent pain, constant pain, recurrent severe episodes of dull, gnawing epigastric pain, and subcostal pain. Pain radiates to the back or the left shoulder, aggravated by food and alcohol, often is accompanied with nausea, vomiting, weight loss, progressive weight loss, and inability to work. Analgesic abuse, especially narcotics dependence, loose stools with steatorrhea, oily and malabsorption, and diabetes mellitus. Okay, this slide summarizes the symptoms and the clinical features. Symptoms include abdominal pain in 90% of patients, which tend to be episodic, coming on and off, exacerbated by eating, especially containing alcohol. After some time, these symptoms get burnt out with periods in the late phase. There's weight loss, either due to avoidance of meal because of the exacerbation of pain and malabsorption. And then there is also the exocrine insufficiency leading to steatorrhea and malabsorption.
Okay. What are the differences between acute and chronic pancreatitis? As for the pathology, acute pancreatitis is a neutrophilic inflammatory reaction, whereas chronic pancreatitis is mononuclear infiltration with fibrosis. For the serological markers, mostly present with elevated amylase and lipase for acute pancreatitis, but in chronic pancreatitis, the amylase and lipase tend to be within the normal range. As for the symptoms, in acute pancreatitis, almost always an acute painful crisis. Whereas in chronic pancreatitis, even though pain and pancreatic insufficiency are the most common symptoms, there may be long periods of asymptomatic periods of remission in many patients. The differential diagnosis of chronic pancreatitis include two groups. One more common, including acute cholecystitis, acute pancreatitis, intestinal ischemia or infarction, obstruction of the bile duct, common bile duct, pancreatic tumors, peptic ulcer disease, and renal insufficiency. Whereas less common list of conditions as shown here. Okay, what are the investigations for chronic pancreatitis? First, blood. Blood tests include FBC and CRP, serum amylase and lipase, blood sugar and liver function tests, stool fecal fat, and very important, elastase level in the stools. It should be low. Pancreatic function tests such as the secretin stimulation test. Among the imaging methods that are used is a plain X-ray abdomen, which may show calcification in the pancreatic area. CT scan is diagnostic in late cases, but early cases may not show up any changes. MRCP will show the biliary anatomy, duct abnormalities, including blockage, stone, and stricture of the pancreatic duct. ERCP is diagnostic and may be therapeutic in cases where you can dilate the pancreatic duct and place stents in the pancreatic duct. And lastly, endoscopic ultrasound or EUS, which has the advantage of that it gives you a closer view of the pancreas. At the same time, you can do a biopsy to rule out malignancy. In the investigations, apart from the urine tests and serum amylase, blood glucose should also be done, which may show an elevated level due to secondary diabetes mellitus in chronic pancreatitis. LFT to ensure that there's no concurrent obstructive jaundice in these patients. Now, a word about this fecal elastase level, which is very important in the diagnosis of chronic pancreatic insufficiency. It will be low in most cases of chronic pancreatitis with exocrine insufficiency, and this can often aid in the diagnosis of chronic pancreatitis. Okay, elastase is an enzyme produced by the pancreas. It is excreted into the bowel to aid with the digestion, and importantly, does not undergo any significant degradation during its transit in the intestine. As such, any exocrine dysfunction in chronic pancreatitis will present with low fecal elastase levels. Okay. This is a plain X-ray of abdomen of a patient it shows massive or extensive calcification of the pancreas in the region of the pancreas here. Okay, this is a sign of chronic pancreatitis. So a patient with classical symptoms and a plain X-ray, these calcifications are almost diagnostic of pancreatic chronic pancreatitis. Okay. This is another CT scan image of a patient with chronic pancreatitis. You can see from the head, body and tail, the whole pancreas is calcified. Extensive calcification with dilatation of the ducts in between, which are diagnostic of chronic pancreatitis. Okay. Another CT scan showing you calcification in the region of the pancreas. And this slide here, this image here shows you a large pseudocyst formation in the head and body of the pancreas. Okay, this is an EUS image of a patient with chronic pancreatitis. Okay, here you can see the pancreas, the dilated ducts here, okay, at areas of calcification. Okay, so the hypoechogenic foci indicates the dilatation of the ducts, which would be minimum of 4 millimeters in the head of the pancreas, 3 millimeters in the body, and 2 millimeters in the tail of the pancreas. Anything more big dilated than this is considered abnormal. Hypoechoic strands are irregularly located throughout the pancreas with lobularity, hypoechogenic duct margins, heterogeneity, visible branch and ducts, shadow calcification showing intraductal stones, and the presence of cysts throughout the pancreas. This is a ERCP image of chronic pancreatitis. You can see here, these are the strictures with circulations of the pancreatic duct, which look like chains of legs or beaded appearance. And these are necessary before any operation can be done on these patients. Okay, now we come to the management of chronic pancreatitis. The three main factors to consider in the management of these patients will be pain, malabsorption, and diabetes. Okay, for the pain, normally they are given analgesics as the mainstay of management on most cases, and many of these patients become dependent on the use of opiates. Malabsorption is secondary to the exocrine dysfunction and may benefit from replacement therapy, including lipases such as creon, enzyme plaques, and also the replacement of fat-soluble vitamins A, D, E, K. Those with pancreatogenic diabetes may benefit from the use of insulin regimes instead of oral regimes. The steroids that may be used and is effective at reducing symptoms in chronic pancreatitis with an autoimmune etiology. High dose of prednisolone is usually used to bring the symptoms under control, followed by a low dose of maintenance regime.
Okay, treatment of chronic pancreatitis is mainly medical, threefold. Okay, a three-pronged attack to treat chronic pancreatitis. Pain control is one of the most important because, as I said, these patients are in chronic pain, and which prevents them from eating and also prevents them from doing work, and they are progressively losing weight. As a result, pain control is one of the most important things to consider in a patient with chronic pancreatitis. Then, to improve the digestion by giving digestive enzymes orally. Okay, one such example is creon, improve the digestion. And thirdly, to control diabetes, which in most cases is invariably present. Most of them may need insulin treatment replacement. Then there can be some surgical interventions to relieve the pain, okay, such as to relieve the obstruction of the pancreatic duct, and also to treat the pseudocysts, abscess, ascites, whatever accumulates in the pancreas, to drain them off. These are things. And these can be number of procedures that can be done. Endoscopic pancreatic sphincterectomy, okay, to relieve the obstruction of the pancreatic duct. Endoscopic placement of stent across the pancreatic strictures. This is another thing that can be done to relieve the obstruction and thereby the chronic inflammation and pain. Drainage of pseudocysts if present, and surgery to remove mass lesions and relieve obstruction. So if the patient has got severe inflammation, localized inflammation, you may want to go and do some pancreatectomy or distal pancreatectomy to relieve the symptoms.
What are the indications for surgery and endoscopic manipulations? Most of the time, in 90% of cases, it is pain is the main reason for these interventions. Others include suspicion of a mass lesion and malignancy, biliary and pancreatic obstruction, duodenal obstruction, pseudocysts of the pancreas, internal pancreatic fistula, especially fistula into the small intestine, and vascular problems such as vein thrombosis, such as the splenic vein or the portal vein thrombosis. Surgical intervention is now rarely performed in many cases of chronic pancreatitis due to the high morbidity and mortality with little or no symptomatic improvement in a significant number of patients. Endoscopic management is becoming more popularly done these days. It's performed only in a select few, and this is also performed in a select few patients where there is a targetable underlying cause, such as a stricture. Endoscopic retrograde cholangiography or ERCP can be used for diagnostic and therapeutic purposes, including removal of stones from the pancreatic duct, stent placement, or sphincterotomy to relieve the obstruction. Endosonography or EUS, which is another method being used nowadays, where it is used as a guide to block the celiac plexus to reduce pain. So celiac plexus blockade with EUS guided methods is becoming also a method for treatment of pain. The other one is for thoracoscopy, flankinectomy, or the blockage of the sympathetic system to the abdomen, also to relieve pain.
The operations that are available is pancreatoduodenectomy or Whipple's operation, whereas the duodenum is preserved, resection of benign mass, lesion of the pancreatic head. If it is involved the head, remove the head of the pancreas, and that is known as pancreatoduodenectomy or Whipple's pancreatectomy. Or you can do a longitudinal pancreatojejunostomy where you anastomose a loop of bowel sideways to the pancreatic duct, open pancreatic duct, and thereby allow the drainage into the bowel. Or you may want to do a total pancreatectomy, removal of the head and the whole pancreas, which is a very major operations with high mortality and still no guarantee of pain relief. So this is done as a last resort when all other things have failed.
This is another bypass operation known as the Pestos procedure, which is a pancreatojejunostomy, where the dilated pancreatic duct is joined side anastomosis with a loop of jejunum. So pancreatojejunostomy. The duct is open up, and there's a side-to-side anastomosis between the pancreatic duct and the jejunum. This is before. This is the stomach. This is the pancreas. You see a dilated duct, and this is before the operation. This is where a loop of jejunum is used to anastomose sideways to this pancreatic duct. That is a pancreatojejunostomy. This helps into drainage of the pancreatic duct, therefore release the pain and symptoms. Generally, the prognosis is poor. It tend to become chronic, debilitating, painful with no cure. Overall mortality 30% at 10 years and 55% at 20 years. The risk of pancreatic cancer is around 4% at 20 years. So the longer the condition, the higher the risk of pancreatic cancer. 4 prognostic factors on chronic pancreatitis includes younger age, smoking, continuous alcohol consumption, liver cirrhosis, comorbid illness such as heart or other medical illness, and cancer. Now, comes to the prognosis of chronic pancreatitis? So, chronic pancreatitis is associated with significant morbidity, reduced quality of life, and a challenging condition to manage for the patient as well as for the medical personnel. In some patients, the disease may eventually burn out after many years of intractable pain, leaving residual endocrine and exocrine insufficiencies. Pancreatic malignancy is a risk in those who have the disease for more than 20 years or so. Or it may be due to new or evolving symptoms should therefore undergo investigations. So the natural history of chronic pancreatitis can be divided into 3 categories. First, when there's a normal, there's normal pancreas. The first stage is the early chronic pancreatitis, which occurs within the first 3 to 5 years, where there is acute relapsing pancreatitis and chronic recurrent pain. And in these cases, the diagnosis is usually done by ultrasound and CT scan, and nowadays by endoscopic ultrasound and biopsy. Sometimes you do a secretin stimulation test and other pancreatic function tests. Treatment consists of medical therapy for pain, avoid toxins, especially alcohol and smoking, analgesics, non-narcotics or low potential narcotics such as tramadol. Nowadays, gabapentins are also being used for these patients. As the disease progresses from 5 to 10 years and beyond, it becomes late chronic pancreatitis. Again, the symptoms are worsened. There's chronic or recurrent pain, pancreatic insufficiency, pancreatogenic diabetes, and secondary pancreatic cancer. CT is usually diagnostic. MRI, MRCP usually diagnostic. Fecal elastase is diagnostic of malabsorption for pancreatic insufficiency, and HbA1c for diabetes mellitus. So these are the tests that must be done for late chronic pancreatitis. And the treatment for these patients includes continued medical therapy for pain, endoscopic or surgical therapy for pain, especially if the pancreatic duct is dilated or strictured, pancreatic enzyme replacement, add vitamin D and calcium, and nutritional assessment and monitoring. And of course, proper treatment for diabetes mellitus. Okay, the key points or the take-home points from this lecture. Chronic pancreatitis is caused by chronic alcohol excess in the majority of cases. Patients present with constant central abdominal and back pain, along with features of endocrine and exocrine insufficiency. Reduced fecal elastase and CT scan imaging can be used to confirm the diagnosis. MRCP and ERCP are usually needed to give a clearer picture of the pancreatic ducts. Management is basically based around symptom control, optimizing the analgesia, and nutritional support and counseling. The treatment is hard, prolonged, and challenging. Thank you for joining me for this lecture on chronic pancreatitis.